Hi friends, it's Justin here, one of your instructors for Low Country. I thought we would put together a Supraglottic Airway station video for you. I don't have another examiner here, so I'm going to go to the station myself. So this will require you to use some imagination as to there being an instructor here, and I hope that you're following along with me down the Supraglottic Airway sheet. I want to remind everyone that in most states, I won't say most, in some states, supraglottic airways are reserved for advanced EMTs and above. Thankfully, in the state of South Carolina, we know that our EMTs are more than capable of placing supraglottics, and it is available for you here in the EMT scope of practice. Why am I saying this? Because if you go looking for the supraglottic airway sheet under the EMT state or national sheets, wherever you find them, my students have a link on Moodle. If you need that link, let me know, 843-496-0129. I'll get you that link. But wherever you're looking at that, it's under the advanced section. Supraglottic is not under typically the EMT section. There's the reasoning for that. So if you need help finding that sheet, let me know and I'll get you that sheet. But I'm going to demonstrate that station for you, and we're going to pretend there's an examiner here and I'll be the student. Before we do that, I'm going to explain everything that you see on the table here and what you would likely see that day when you walk into the National Registry and take your exam, psychomotor exam, and if you were to get this station. So, before you, we have the mannequin and the patient, 2 lungs, 1 belly, just like you, I guess. Most of us, anyways. We have a bag valve mask here, and I remind my students all the time, that's not magic. There's a bag, there's a valve, and there's a mask. This one has a PEEP valve on it. You'll learn about PEEP later. I'll probably do another video on PEEP as it relates to the EMT student. We don't try to talk above your heads or dig you too deep, but this is used in the practice of an EMT, and so we'll one day have a video on that. But for now, you'll just be looking at the bag valve mask. This is how we provide ventilations, as you know. We have an OPA, an oropharyngeal airway here. We know that the job of this bad boy is to get the tongue of an unconscious patient with no gag off of the back of the hypopharynx so that the airway remains open and patent for ventilation, air in and air out. If you're unconscious and you're not able to protect your own airway, your tongue will likely close off your airway. And so this piece of plastic does nothing more than open that up, as you already know. We have a number 3 King tube here. Typical adult sizes are 3, 4, and 5. Depending on the height of your patient. So we'll be using a number 3 today for demonstrations purposes. I have a 60 cc syringe here. You know that a typical King supraglottic airway requires 60 to 90 cc's of air in order to inflate the bulb and use the airway as it was intended. We have a Thomas tube holder, which will secure our airway in place in the patient's mouth. Some suction, should we need it, and anytime you're interacting with a patient's airway, suction should always be available to you. That's a rule you need to commit to yourself in your practice. You need to always have your suction available for you, whether you're an EMT, an advanced practitioner, or if you're a paramedic practitioner. So you need to have that. Oxygen tank here, which you will likely see that day on testing, but a lot of that may be verbalized, so maybe you'll hook it up to oxygen, maybe you don't. Maybe they say you can verbalize that. We know that that takes place in the exam to help in time, so don't let that distract you or confuse you. All right? So without further ado, hoping that I don't miss any of the chronological points on the sheet, otherwise this video will get a second due. I'm going to begin with the station and demonstrate that to you now as to what we expect of you when you're performing this station. I'm going to bring out my stethoscope because I did not put that on the table already, so let's get that out on the table. And this should probably be around your neck on exam day so that there is no odd distracting period of you trying to get it on your neck or around your ears when it is exam time. So I always tell my students to go ahead and put that around your neck, okay? It's easy to one-handedly work this up to your ears than it is to try to get the whole thing on. And that'll make more sense in just a minute. So here we go. The supraglottic airway station. I'm going to go right down the sheet. So I'm going to walk up to the patient. I'm going to advise the examiner that I have on my BSI and that my scene is safe. I'm going to walk up to the patient. Maintaining airway is always done from the head, if at all possible. And so I'm going to manage it from the head, opening the head with a head tilt chin lift, and I'm going to ask the examiner, what do I find? Is the airway clear? They tell me that the airway is now open manually, and it is clear. So at this time, I will size an OPA from the corner of the patient's ear to the corner of the mouth and find that this is an appropriate size. I will then use a scissor technique to enter the side of the patient's mouth with my OPA sideways, and I will work it down into the normal hypopharynx or anatomical structure of the patient's airway, going towards the patient's natural anatomy. And then I will ask the examiner if the patient accepts. And the examiner says that the patient does accept, so I will begin ventilating the patient on room air initially, one breath every 5 to 6 seconds. 1, 2, 3, 4, 5. I do require my students to count out loud because you don't want the examiner to be counting for you. Maybe your 5 or 6 seconds is a smidge different in cadence than theirs. So I would like my students to count out loud so that there's no question. 2, 3, 4, 5, 6, breathe. 2, 3, 4. The examiner is going to say the patient is being ventilated with bilateral chest rise and fall, and that the pulse oximetry, that's an alarm, sorry, the pulse oximetry is reading 85%. Well, if pulse oximetry is low, then let's hook up oxygen, okay? So I'm going to ask the examiner if that's something I need to do manually or if that is something we can verbalize. And the examiner says that we can verbalize. Notice that I'm walking and talking. I'm breathing for the patient and talking to you. We expect the same of you when you're interacting with the examiner. 1, 2, 3, 4, 5. So the patient's now hooked up to 15 liters per minute of oxygen hooked up to this BVM. Okay, and so now I have 15 liters per minute of oxygen on this BVM, and they are going to tell you that at this time Med Control has ordered the placement of a supraglottic airway. And so now that I have an order to do that, notice that the sheet is being led by the examiner, not by you. Now that I have an order to do that, I will turn the breathing over to my examiner or to a partner, and I will begin going through the process of placing a supraglottic airway. So I'll have the examiner take over ventilation. Breathe for me, please, at one breath every 5 to 6 seconds. And now I'm going to check my supraglottic airway. I have a number 3 king here. This number 3 king has about, per the instructions right here on the tube, there's no guesswork involved. You can just simply look at the tube and it'll tell you exactly what we're expecting to do here. So it tells me that we need 40 to 55 mLs here, so I'm going to gear that up on my syringe. And I'm going to inflate it to check for leaks. Okay? I want to make sure that the tube inflates and does not collapse again. And then I'm going to remove that same amount of air carefully without popping the whole syringe out, and then lay the syringe right by the patient. And so now I have an airway that does not have leaks. I would, at this time, lube the distal tip. The distal tip is simply this area here. Okay? I do not want to lube this area. I want to lube this area. Okay? So keep that in mind. So now that this is lubed and ready to go, it's checked and it works, the equipment is fine, I will tell the examiner they can stop breathing for me, and we will move the OPA out of the patient's mouth. With the OPA out of the patient's mouth, I will go ahead and head tilt chin lift the patient again, get the airway open, and then I will tongue jaw lift. I'll reach down, I'll grab the tongue. Remember, they don't have a gag, they're unconscious. I'm going to grab the tongue, I'm going to pull it up towards me, not this way, this way. Pull it up towards me, and I'm going to insert the device in the open hole. There are lines on the back of the king tube, and you can use those as guidance for how deep you go. When you meet definitive resistance, stop. Too deep is too bad, too high is too bad. So you've got to practice with this in order to be proficient. So now that I've got the airway in place with some definitive resistance, I'm going to go ahead and administer the air that I've already prepped in the tube. Do you have to hold on to the tube at all times? No, you do not. Do you have to be cognizant of the tube and not just let it hang out all willy-nilly? Yes, okay? You need to pay attention to the tube. So I'm going to go ahead and hook my BVM up, and I'm looking for bilateral chest rise and fall. Step 1, do you have chest rise and fall? Same rate, 1 breath every 5 to 6 seconds. And it is very clear that I do have bilateral chest rise and fall. With that intact, I will go ahead and confirm in an additional way that my tube is well placed. So I'm going to give the BVM over to my examiner, and I will have them breathe for me. So we're going to use our imagination here again. So they're going to breathe for me while I listen for gastric sounds and lung sounds. They're breathing at 1 breath every 6 seconds. I'll listen first over the gastro, and I want to know, is there gastric sounds? Are there gastric sounds? And I would hope the answer is no, because we don't want air in the belly of the patient. Then I'm going to listen over the left lung, and then over the right lung. And I want the examiner to tell me that the lung sounds are clear and equal bilaterally, and that there are no gastric sounds. That is indication that my tube is well placed. I now have bilateral chest rise and fall. That's one confirmation method. I now have no gastric sounds with clear bilateral breath sounds. That's a second confirmation method. So I'll take the ventilations back over. Okay? And I will continue to secure the airway, breathing 1 breath every 6 seconds. So now that I'm ready to secure the airway, I'll give this back to my examiner. Okay? And I'll go ahead and secure the airway with a Thomas tube holder. My examiner is breathing 1 breath every 6 seconds. I'm going to work the Thomas tube holder around the airway. Work it around the airway first. What I don't want you guys to do is attempt to get it all in the mouth and around the airway in one go. That tends to be problematic. So get around the airway first. Once you get around the airway, move the airway over to the right, push the chin away, and then the bite block will go past the teeth, and it will allow you to secure the airway. When you are secure, it should be flush to the patient's lips, and the airway should tighten down nicely. And there should be no big gap between the Thomas tube holder and the patient's face. It should be flush. Okay? So now that that is tight, I'll work this through the back of the patient's cervical spine space. Remember that the examiner is breathing for me 1 breath every 6 seconds. And then I'm going to just pull the airway down. And so the same thing that's happening over here on the side that you can't see is exactly what's happening over here on the side that you can see. This just comes right down on top of itself and velcros to the other side. So before I say this airway is secure, I want to make sure that it is tight at the tube, it is tight on the right strap, and tight on the left strap. Once that is done, I now am confident that my airway is secure and in place. Now I'd like to place the patient on end tidal capnography and capnometry. So I'll go ahead and pull the BVM off and tell the examiner to hold off on the breathing for me. I'm going to put my live capnography and capnometry tube hooked up to my capnography monitor, and I'm going to breathe 1 breath every 6 seconds. If my airway is still in place and working effectively, I should see a metric value of 35 to 45 millimeters of mercury. That's my metric value of carbon dioxide being exhaled from the patient's lungs. That tells us that the tube is in the right space because, in theory, you can't be releasing regularly, consistently, carbon dioxide from the stomach. So I want 35 to 45 in metric values, and then I want square wave forms. If I am monitoring that with every single breath, And every time I ventilate with this BVM, I'm getting that metric value and waveform capnography on return. Then the airway remains in place. This is the most definitive way to monitor a patient who has an advanced airway in place to make sure that the therapies we're intending to provide are actually being provided. Okay? So end-tidal CO2 is expected of you. 35 to 45 and square waveforms. That's what we're looking for. In addition to that, I would tell the examiner I'm looking to see the patient's color improve. I would hope that they would be pink, warm and dry. And I'm also going to place the patient on SpO2, looking to have the patient oxygenated above 94% or better. Okay, 94% or better. Once you've done that, once you've made that spill, they might ask you, how do you know how much air to deliver with the bag valve mask? And the answer to that question is always the same. We only squeeze the bag enough to cause chest rise and fall. And that will conclude the station. You have successfully placed a supraglottic airway in an unconscious, no gag patient. You were successful in that placement. You are ventilating with bilateral chest rise and fall and monitoring with continuous capnography and capnometry. And that would conclude the station. If you are using colorimetric devices, that's also acceptable. If you don't that day have the tubing that makes it live, that hooks up on the other end to a monitor that gives you a digital readout, that's completely fine. You can use the colorimetric caps, which also go right on the end of the King airway here. You would connect your BVM and you breathe for them, expecting that they would go from purple to yellow. And if they do so in about 3 to 6 breaths, that is a positive indication that the tube is in place. I want to remind everyone that there is no one method for confirming an airway. The confirmation of an airway is ongoing and diverse. It requires a thorough assessment of multi-factors, including good chest rise and fall, no gastric sounds, clear lung sounds, a patient that is overall improving in color, in SpO2, and then that definitive, very successful and standard of care method of monitoring end-tidal CO2. Capnography, which is your waveform, the capnograph, that's a square, and then your capnometry, metric means number, and that should be 35 to 45. There's a lot in this station, and that may be daunting and intimidating, but this is not intimidating, and you will bridge the gap of you feeling like you don't kind of have this under control with practice. The more you practice this station, the more you're going to feel like you've got this. I want to assure you, we, the instructors at Low Country, want to assure you that this is your wheelhouse, and you guys do a phenomenal job with these airways. The data is sure of that. And so I want to thank you for your diligence in this station. It is very important that we, in the pre-hospital setting, can throw the EMT through to the airway and know that it is being managed top-notch. So thank you for that. Thank you for your time watching this video. Stay safe out there, and I'll see you on the next one. Thank you, guys.